should start straight off. Nicola's going to start us looking at the ovarian cyst guidelines. And I think Nicola and Vikram, you both said you're happy for people to ask questions if they want mid-presentation, so it's a conversation, or do you want them to people to leave it until they are we come to the end of the presentation, which is easier for you?
Just because of the amount of stuff we have to cover today, it might be easier to just put messages in the chat,
Yes.
Q&A section, and we can address them at the end.
And yeah, that's absolutely fine. And we'll also go through the chat at the end of the meeting. If there's anything else that's not being covered, we'll let everyone have an answer to that. So ideally, please keep yourselves on mute when you can. Use the chat function as we've described, and raise your hand during the Q&A session at the end if you need to ask a question. It's always great to hear people vocalise their questions. So I think that's it for housekeeping. I don't think we have anything further. And for those of you who aren't aware, the Cancer Alliance, we're one of 21 Cancer Alliances in England. We are part of the NHS, and we cover the boroughs Barnet, Camden, Enfield, Haringey, Islington, which of course are the NCL boroughs. And we work parallel with GP practices, with hospitals, trusts, with commissioners, with charities and Department of Health and NHS England and our local councils, just to all to do with cancer, improving cancer outcomes, improving access for cancer therapies, and ensuring that we're all clear from primary care perspective about the hospital guidelines and how they work for us in terms of referring people in and onward management. So let's start, I think. Nicola, thank you. I think that's lovely. Let's go straight.
Great, thanks very much. Simon, if you could move to the next slide, please. Thank you. I'll just give a bit of background as to why we have revised the ovarian cyst guidelines and introduced a new pathway for unscheduled bleeding on HRT. Across London, the referral rate to the urgent suspected cancer pathway has exponentially risen over time. And you can see what used to be called the 2-week wait pathway, now the urgent suspected cancer pathway. Referrals have risen dramatically, particularly since the pandemic within NCL. Next slide. Interestingly, though, the conversion rate to cancer has not really changed. So we're seeing an awful lot of patients, but still not picking up more cancers. So most of the London networks are still down in that left-hand corner, picking up around about 2 to 3% cancers out of their referrals. And I've just put a little plot next to that of just a month's snapshot at UCLH in October 2023 of the sort of referrals we're getting to the urgent suspected cancer clinic. The vast majority revolve around abnormal bleeding, postmenopausal bleeding, unscheduled bleeding on HRT, and other abnormal bleeding. A significant proportion of patients have an ovarian cyst. The majority of those, though, will not necessarily be a cancerous cyst. We do see patients with just a raised CA125. That's been on our urgent suspected cancer referral form for about 7 years across London, and also women who are asymptomatic but have a thickened endometrium. So all of those things are being addressed over time, but these two new pathways are to try and accommodate the patients who are the most commonly referred, but not always appropriately so. Next slide, please. So what we've been doing over the last couple of years is having a really in-depth discussion with our colleagues in health primarily, because we identified that one of the difficulties that primary care physicians were encountering was that the reporting of scans was leaving them in a position where they had no choice but to refer to an urgent suspected cancer pathway. So we've been working really closely with our ultrasound providers, and I can see that a few of the leads are on the call today, which is brilliant. And we've now come up with standardised reporting texts, which have been used in certain patches within NCL, but have now been extended and agreed upon within all of our colleagues in the ultrasound providers. We've now got new guidelines for ovarian cyst management and unscheduled bleeding on HRT, which have been very widely reviewed by primary care representatives, community gynae, all the ultrasound leads, our gynae radiology leads, prescribing advisors, and we're just waiting for final governance sign-off. We were hoping to introduce the pathways and launch them on the 14th of October, but we've had to just pause that for a minute while we wait for the final sign-off. During the process of us making our guidelines, lots of audits were done within the UK, and the NHSE team came up with a deliverable that we have to now see 80% of patients with unscheduled bleeding on HRT outside of an urgent suspected cancer pathway. So while we were devising our pathway, the British Menopause Society and the British Gynae Cancer Society produced a guideline which was released in the spring, and that's been the basis for most of our pathway, but there are some subtle differences for local implementation. And we've also had to revise the Pan-London guidelines for urgent suspected cancer referrals to accommodate what is within those guidelines. Next slide, please. So we have two flow sheets within the wider guideline for ovarian cyst management, one for premenopausal women and one for postmenopausal women. So if we can go to the next slide, I've just split it up into simple cysts and complex cysts. Simple cysts in premenopausal women are almost universally functional cysts, some of which will persist for 2 or 3 cycles, but all of the research that's published on simple cyst almost universally says that they are very low risk for progression to cancer. So a simple cyst by definition is just a simple thin-walled sac of fluid with no solid elements, no walls within it, no nodules, papillae. So if you have a small simple cyst in a premenopausal woman, you can generally reassure them and they don't need any follow-up. However, if it's quite a large cyst, firstly, it's slightly more likely to become something more suspicious, but also it can be difficult when you have very large cysts on ultrasound to be absolutely sure you haven't missed a small soft tissue element. So having an MRI scan when you have a cyst of more than 10 centimetres is usually advisable. And in this guideline, we said that if it can be requested using a direct access request, all well and good, but ultimately women, premenopausal women with a large simple cyst generally require routine referral to gynecology. They don't need to come to an urgent suspected cancer clinic. But there's a group in the middle who have a 5 to 7 centimetre cyst where we do think that a repeat scan would be advisable, just to make sure that that cyst isn't getting significantly larger, is not developing any worrying features and isn't becoming more symptomatic during that time. But the majority, as I said, will be functional and they will resolve before that scan. They may obviously have developed a new cyst, but that's usually comparable. They can compare that within the ultrasound. But if somebody has a persistent or an increasing size cyst, or they're becoming more symptomatic, they should be referred to routine gynae. Anybody who has a cyst that is suspicious of cancer should be referred on an urgent suspected cancer referral pathway. And this will be a very small proportion within the premenopausal group. Ideally, those women should have some tumour markers taken. You'll notice we haven't mandated any CA125 tests within this group because the specificity of CA125 in premenopausal women is not brilliant. Obviously, if you have endometriosis, adenomyosis, if you take the CA125 while the woman's on her period, or they have a cold, any inflammatory condition, the CA125 will be artificially elevated. So although we do like to see a CA125 when we see the patient in secondary care, we wouldn't want you to delay referring somebody with an abnormal morphology on a scan just in order to wait for the CA125. We've also incorporated hemorrhagic cysts with typical features in this part of the guideline for premenopausal women, because most hemorrhagic cysts in young women will be classical corpus luteum where there's a bit of hemorrhage, and that will have typical features for the ultrasonographer to interpret. If that's the case, then they can be managed as a simple cyst. But if they have any other hemorrhagic features or it's difficult to distinguish from an endometrioma, then they'll be managed differently. But there are now standardized reporting texts for all of these categories where the morphology of the cyst will guide you what to do. But if a repeat scan is required, then the ultrasonographers will automatically request that, and it will be stated within the request that a scan has been rebooked, within the report that a scan's been rebooked. However, we haven't been able to mandate automatic upgrades by the sonographers for anybody with a concerning cyst. There just isn't the governance process at the moment, and although the NCL Imaging Board are very keen to have automatic upgrades, it's very time consuming and will have an impact on the capacity of the units because the sonographers will take time to do automatic upgrades. So at the moment, if the sonographer is very worried about somebody's scan result, they will inform you in the same way as they do at the moment. If we can go to the next slide, please. Moving on to complex cysts, the majority of complex cysts in young women will not be cancer, but if somebody has suspicious cyst with features of malignancy, then again they need to be referred to the urgent suspected cancer pathway, ideally with a CA125, but again not delaying their referral to wait for the CA125 result. Some will have a hemorrhagic cyst with typical features and they'll be managed like a simple cyst. But in the middle, there are three categories there: dermoids, endometriomas, and unclassified cysts. A proportion of women will have an unclassifiable cyst, but there's no overt concern about malignancy. They may have a multilocular cyst, for example. So it doesn't fit into the simple cyst category, but it's not as worrying as somebody with features of malignancy. Those patients should be referred for routine gynecological assessment in secondary care. Dermoids and endometriomas have a really low risk of progression to cancer. Dermoids, about 1% will be immature teratomas, or even more rarely, a malignant teratoma. Endometriomas have about a 1 to 2% risk of having a cancer within them. So we've agreed with our community gynae colleagues that asymptomatic or minimally symptomatic women with dermoids and endometriomas less than 5 centimetres are ideal for management within community gynae. And we have agreed some text for information for patients and also to help management within community gynae. So if you don't have access to community gynae services, then a routine gynae referral to secondary care would be appropriate, so that patients can have a discussion about the pros and cons of surgery versus conservative management. I think it's worth noting that dermoids do have a risk of torsion. Endometriomas less so, because they tend to be more adherent, so less likely to twist. About 25% of women who have a torsion will have a dermoid, but the risk of torsion isn't directly proportional to the size of the cyst. So it's worth mentioning to patients who have any kind of large cyst or a heavy cyst like a dermoid that there is a potential risk of a cyst accident, whether it be bleeding, torsion, and they should be made aware to present to casualty or to whoever is most appropriate if they do get acute symptoms. For women with dermoids and endometriomas on scan who have symptoms or larger cysts, we've recommended routine referral to secondary care gynecology. They don't need to come through on urgent suspected cancer pathways. And the standardised reporting will hopefully be much more useful to you, much more directive in what to do. It won't just say complex cyst, consider urgent suspected gynae cancer referral. It will actually give you some sort of summary of what the sort of cyst is and what the most appropriate management will be. If you can move on to the next slide, it covers postmenopause. Oh, sorry, these are the auto texts that you'll see that we've agreed to. So for the first scan in a premenopausal woman, if it's a small cyst, then it will say that it's most likely to be a functional cyst with no further follow-up required. For a slightly bigger cyst or a hemorrhagic cyst with typical features, it will recommend a further follow-up, but will include the date and time of the next scan. And likewise, all of the other scenarios that are on our flow sheet will be covered by a standardised auto text. It's not possible to do that for postmenopausal women because, as you'll see from the next slide, we've asked for CA125 to be included for postmenopausal women. So if we can move on to that slide, please, Simon. We've again categorised these as simple and complex cysts, and this is relevant for any woman who has had more than a year since her last period or is on any type of HRT. Women who have a complex cyst and are postmenopausal or who have large, multiple bilateral cysts or are symptomatic should be referred urgently for an urgent suspected cancer referral. Ideally, again, with a CA125 result before they come, but don't wait to refer in order to get the CA125. The morphology alone is enough to refer that patient. But it's really important to know that simple cysts are very common even in postmenopausal women who are not cycling. So those cysts are more likely to be cystadenomas or cystadenofibroma. In those patients, the large research studies of tens of thousands of women show that about 30% of those women over the subsequent year, their cysts will resolve, but 50% will still have a persistent cyst. So it's not unusual for a postmenopausal woman to have a simple cyst, which you see on repeated scans. But the likelihood of those cysts becoming malignant is reported to be somewhere around 6%. So what we've said in our flow sheet here is for low risk cysts, very small cysts, have a CA125. There's a good negative predictive value for CA125 in this scenario. If the CA125 is normal, they can be reassured with no follow-up. Obviously, if the CA125 is abnormal, they need to come to us on an urgent suspected cancer referral. But the middle group are probably going to be the largest group. Women with a cyst somewhere between 3 and 5 centimetres. It's unilateral, they're pretty asymptomatic. Normal CA125, they'll be asked to have a repeat scan in 4 months' time, again with another CA125. Proportion of those will have resolved, about up to 30% will have resolved, and they can be reassured. Some, 50%, will go on and need to have another scan. But if by 10 to 12 months those women have still got a very stable cyst, simple cyst with a normal CA125, they can be reassured and discharged. There is provision within this flow sheet for any abnormal CA125, any abnormal features to be upgraded to an urgent cancer referral. But because we would like a CA125 taken when these ladies are found to have cysts, the ultrasonographers will give guidance as to what to do next based on the flow sheet, but they won't be able to automatically request repeat scans. So those requests will come back to you for interpretation of the next CA125 and another scan request. Could you go on to the next slide, please? So just to summarise ovarian cyst management, most premenopausal women with cysts can be managed outside of an urgent suspected cancer pathway. CA125 shouldn't routinely be taken in premenopausal women with ovarian cysts unless there's a suspected cancer seen on ultrasound, and even then, don't delay the referral to an urgent suspected cancer pathway just to wait for a CA125 result. Standardised reporting texts have been agreed across all providers, and they will give guidance based on the cyst size and morphology. Repeat scans will be booked for premenopausal women, but not for postmenopausal women where CA125 is required. And sonographer upgrades aren't yet going to be incorporated into these guidelines, but may over time come in when the right governance is there. Just a word about incidental cysts that are found on CT or MRI that are done for other reasons. CT is not a really good modality for looking at the morphology of ovarian cysts. So in general terms, we would say if they haven't reported very clearly what the cyst is, if it hasn't been characterised adequately, request an ultrasound scan, not urgently unless there's a real concern on the CT, but those can be direct access scans just to get good morphology on the cyst, and then they can be managed according to the pathway. Cysts identified on MRI have usually been categorised very clearly on the morphology, so they can be managed as for an ultrasound detected cyst. But be mindful that radiologists will not usually request a CA125. It's a little bit individual, and we haven't been able to standardise that reporting. But in the guidance that goes along with the flow sheets, we have given a little bit more information about risk assessment that's used for MRI and CT, and it's largely the same or very similar to the risk assessments we've done for categorising how you should manage ovarian cysts. So I'll move on now to unscheduled bleeding on HRT, but I'll be very happy to answer questions at the end on ovarian cysts. So if we can move to the next slide, the rationale for the unscheduled bleeding pathway being introduced is we're trying to avoid unnecessary investigation of women who are at low risk of endometrial cancer, who experience bleeding on HRT within 6 months of initiating treatment or within 3 months of a change in dose or preparation in those who have already established their HRT management. But it's really key to note that unscheduled bleeding on HRT is not the same as postmenopausal bleeding. The definition of postmenopausal bleeding is bleeding in a woman who has been amenorrheic for 12 months or more, who is not on HRT. So if you have a woman who fulfills that definition, they should be managed on an urgent suspected cancer pathway. Next slide, please, Simon. So the reason why we're seeing so much more unscheduled bleeding on HRT is that we're prescribing more HRT. There was a 30% increase in prescriptions for HRT between 2021 and 2022. We're also increasingly prescribing HRT to perimenopausal women, increasing the use of transdermal estrogen in women with complex comorbidities, and we're prescribing higher doses of estrogen. We're also using more micronized progesterone. And it's important to note that unscheduled bleeding in the first 6 months of using HRT, or when you're changing HRT within 3 months of a change, about 40% of women will experience some unscheduled bleeding. So it's really important to set patients' expectations appropriately. Next slide, please. When you look at the endometrial cancer risk in women generally, in the overall population, the incidence is between 0.7 and 1.5%. It's age-related, but there are other risk factors which increase the endometrial cancer incidence. If you have Lynch syndrome, a mismatch repair deficiency, that means you can't repair your DNA properly, that increases the risk by 30 to 50%, and that's associated with an increased risk of colorectal cancer and some other cancers. A lot of people won't know their diagnosis, though, until they get a diagnosis of endometrial cancer. So that is a tricky one. But an American Cancer Institute study showed that for every increase of 5 BMI units, there was a 50% increase in the risk of developing endometrial cancer. So by the time you reach a BMI of 40 or more, you have a 10-fold increased risk of endometrial cancer compared with a woman with normal BMI. There's also an increased risk of endometrial cancer if you have an altered bioavailability of estrogen. So women with diabetes, with a history of PCOS, unstable liver disease, and a number of other conditions. So those things do need to be borne in mind, although it's very difficult to correlate those risks with unscheduled bleeding on HRT, but they do need to be taken into account. The risk of endometrial cancer on HRT per se is lower in women on continuous combined HRT as long as they're not bleeding. In women who are taking sequential HRT at a standard dose of estrogen with appropriate progesterone opposition, where they've started the HRT after the age of 50, they're not bleeding, and they've been using the HRT for less than 5 years, they have the same risk of endometrial cancer as somebody who's not using HRT. But there are increased cancer risks in women using sequential HRT with less progesterone, who've been taking it for longer than 5 years, or are tricycling it with 7 to 10 days of progesterone every 3 months, certainly for longer than a year, and in women who are using unopposed estrogen. But when you look at the risk of endometrial cancer, specifically in women who are bleeding, in somebody who has postmenopausal bleeding, not on HRT, they have an endometrial cancer risk of around about 10%. Overall, women with unscheduled bleeding on HRT have a reported risk of somewhere around 1 to 2%, but it's difficult to interpret that literature because obviously some of it's old, using different types of HRT, it lumps together continuous combined and sequential HRT. But when you look at patients who have presented with unscheduled bleeding, who've been found to have a thickened endometrium, so they're already an enriched population, there's a risk of endometrial cancer of somewhere between 1.3 and 5%, so slightly lower than a woman who has postmenopausal bleeding. Next slide, please. Looking in detail at the outcomes of those women who have unscheduled bleeding, who go through an ultrasound and are found to have a thickened endometrium, still the vast majority have an atrophic or inactive endometrium. On sequential HRT, it may be described as weakly proliferative, but in general terms, it is the majority of people will not have an abnormality in their endometrium. There is a larger proportion of women with polyps, though, who take HRT compared to women who are bleeding without HRT. Hyperplasia and endometrial cancer, very uncommon with continuous combined, slightly increased risks with sequential HRT, but still not as high as women who present with postmenopausal bleeding. So unscheduled bleeding on HRT is a lower risk situation than PMB, but it's not a no risk situation. Next slide, please. So it's really important when you see somebody who has unscheduled bleeding on HRT to do a proper assessment and include a risk assessment for endometrial cancer. So the most common reason for unscheduled bleeding is that patients aren't taking their HRT as prescribed, or they're just not complying generally with their medication. So it's important to know how they're taking their HRT, whether they're complying with it, what drug interactions there might be with their other medications, conditions that promote malabsorption. Think about their bleeding pattern. Although unscheduled bleeding on HRT is common, it's not normal to have heavy, prolonged, continuous bleeding. So any bleeding, even if it's only light bleeding that continues for a number of weeks, that's not normal. So it should be considered for investigation. Consider their smear and sexual history, look at what their BMI is, and do try and examine these women. Make sure you exclude another obvious cause. So have they got obvious vulvovaginitis? Have they got a cervical cancer, an obvious lesion somewhere? Take swabs if they're indicated, do a smear if it's overdue, and don't forget pregnancy tests if it's appropriate, particularly because we're looking after more perimenopausal women. Risk factors for endometrial cancer, although as I said before, it's difficult to completely equate those to risks when you have unscheduled bleeding, it is incorporated into this guideline. So we look at major and minor risk factors, looking at the things that we talked about before: BMI, genetic predisposition. Women with BMI over 40, there's probably only going to be about 5% within this population who fall into that group, a higher proportion who are between 30 and 39. Women with a genetic predisposition, again, a small proportion of patients. And then the risk factors associated with estrogen and progestogen opposition. We can move on to the next slide, please. This is the flow sheet, and it differed. The guideline itself is much longer, is much more detailed, and it links you to the BGCS guideline, which again has a little bit more detail in it. But this flow sheet is very similar to the national guidance, but has two key differences. The national guidance advises a 6-month period of adjustment of HRT. We in NCL on the guidelines committee felt that that was too long, that some women would then be nearly a year down the line from starting HRT before they got an ultrasound, and we didn't feel comfortable with that. And likewise, the national guideline does not give an option, although it is talked about in the text, it doesn't give an option for stopping HRT if women are willing to pause their HRT. So if you take it from the top, there's an assessment of risk factors, bleeding pattern, HRT regime, as we've spoken about. If a patient has 1 major or 3 minor risk factors, or if they're sitting in your surgery and they've got barn door red flag symptoms for a malignancy, they are losing weight unexpectedly, they are bleeding torrentially, and they've got a low hemoglobin, don't faff around with the left-hand side of this form. Go down the right-hand side to an urgent suspected cancer referral. But if patients don't fulfill that high risk assessment, then they go to the left-hand side here. And then you want to see, have they had prolonged or heavy bleeding? Do they have 2 minor risk factors? And under those circumstances, regardless of how long they've been on HRT for, how many times they've changed their preparation, they should have a direct access scan within the community within 6 weeks. And I think that's the area that most people have been slightly uncomfortable about both these guidelines and the national guidelines. Because I think there's a general distrust that we're not going to be able to access direct access scans within 6 weeks. But we've done a lot of work with our providers within NCL who have advised us that they do have capacity, and we have a fail-safe that if we will be looking at the capacity on a monthly basis in our tumour working group, we will also have direct feedback from our providers to referrers that if there isn't 6-week capacity, they'll pass the referral back. And on the urgent suspected cancer referral guidelines now, there is a checkbox for these patients if they, even if they're not high risk and don't fulfill the criteria otherwise for an urgent suspected cancer referral, they will have a scan on a 2-week wait pathway if there isn't capacity. So for intermediate risk patients who have some risk factors or are bleeding heavily, doesn't matter how long they've been on HRT, they should have a scan. But the majority of patients who come onto this pathway, they will be low risk. They won't have been on HRT for more than 6 months, or it'll be less than 3 months since a change in preparation. They won't have heavy bleeding. They won't have risk factors. Those women can go down 2 pathways. They can either be offered a pause in their HRT if they feel that they can manage their menopausal symptoms during that time. If during a period of 4 weeks off HRT they continue to bleed, they should be managed as a postmenopausal bleeding patient, and they should go to an urgent suspected cancer referral for an endometrial assessment. If they stop bleeding when they've stopped their HRT, then they can be reassured that there's very unlikely to be any major pathology in their endometrium, and they can go back on HRT with adjustments and again follow the pathway. If they continue to bleed, then they should have a direct access scan. But if women are not willing to stop HRT because their symptoms are just debilitating, then they can be offered a period of optimization of HRT. And Vikram's very kindly in a minute going to talk us through how to optimize HRT. If bleeding is still carrying on despite optimizing HRT after 3 months, again, they can be given the option to stop. If they don't want to stop, then they should have a direct access scan. If they do want to stop, then they have the same process as women who are willing to stop up front. Now, if a patient has a direct access scan or has a scan through an urgent suspected cancer referral, the guidelines that we're using are the same as the national guidelines for endometrial thickness. There isn't good data about the sequential HRT group, what happens to their endometrial thickness during a cycle. But the vast majority of women will have an endometrial thickness less than 8 millimeters, and the national guideline has plumped for 7 millimeters. So we've kept to that. For continuous combined HRT patients, their endometrium should be no thicker than 4 millimeters. So much like a postmenopausal woman who's not on HRT, who's bleeding, 4 millimeters is the cutoff. There's also a category for women who have incompletely visualized endometrium. That's tricky because the visualized endometrium may be nice and thin, but there's always that concern that in the bit that you haven't visualized, there might be something worrying. But if you do an ultrasound and it comes back with a report from the sonographers, again with a standardized report for interpretation based on the type of HRT the patient's on, if there's no worrying features, then those patients can be optimized for another 3 months. But if after 3 months they're still bleeding, we would recommend they go to an urgent suspected cancer pathway to have a proper endometrial assessment. If somebody's ultrasound is abnormal, they'll need to be upgraded so that they can have an endometrial assessment, which is more likely in those patients to require a hysteroscopy, just because 50% of patients on HRT will have a polyp based on the information we saw earlier. So that's the pathway as it stands. The guideline does have more detail, but it's not vastly different from the national guidance, just those two differences about a pause in HRT or a shorter period of optimization, just so that we're sure we're not going to be missing endometrial cancers. Could move on to the next slide, please. So just to summarise the investigation guidelines, for high-risk women who have 1 major or 3 minor risk factors or barred or red flag symptoms, refer them to an urgent suspected cancer clinic immediately. For women who have prolonged, heavy or persistent bleeding or have 2 minor risk factors, regardless of how long they've been on HRT, they should have an urgent direct access scan within 6 weeks. Women who have unscheduled bleeding starting more than 6 months after commencing HRT or more than 3 months since a change in dose or preparation, again, they should be directed to a scan in the community within 6 weeks. For women who don't have any risk factors, they can be offered a 4-week trial of HRT, and if they continue bleeding, they should be managed as a postmenopausal bleeding patient and have an urgent suspected cancer clinic referral. But patients who opt for a 3-month period of optimization, if they continue to bleed, should have a direct access scan within 6 weeks. And as we're saying, there are standardized reporting texts which all of our ultrasound departments are going to be using to guide you to the next step for these patients. So hopefully it should be fairly easy to work your way down the flow sheet. If we could go to the next slide, I think I'm now going to be handing over to Vikram to talk us through how to optimise HRT for women with unscheduled bleeding, and I'll come back to you later to just talk briefly about the urgent suspected cancer referrals. So thanks very much, Vikram.
Thank you, Nicola. Nicola, Simon, incredible amount of hard work to get these both documents done. There's been so much input over the last few months, so thank you for that. And thank you for the opportunity to go through a few slides. I have about 5 slides quickly. So what happens about optimizing HRT if you have somebody with unscheduled bleeding? What are the common protocols or sort of changes to HRT that we will consider? The first thing to say is we don't know really the mechanisms which underlie unscheduled bleeding in absence of pathology. So you could have identical women with same BMI, same clinical history, and in the same dose of HRT, effectively one continues bleeding, the other doesn't. and we really don't understand what happens at the level of the endometrium, why some women bleed and others don't. It's inconvenient, leads to invasive investigations, expensive tests to exclude pathology. So the aim is to try and change HRT when bleeding happens alongside the investigation pathway to make sure that they stop bleeding, and that prevents future more invasive investigations. Of course, bleeding will have negative effects on patient acceptability. We have had quite a few women who, because of persistent breakthrough bleeding, have eventually decided to come off HRT and consider non-HRT options. We've just discussed the approach to history-taking, examination, investigation, so I'm not going to dwell on that again. But the point to stress is non-compliance is the biggest reason for breakthrough bleeding. It's not the HRT regime. It's because we often tend to prescribe estrogen separate from progesterone, and micronized progesterone, one has to take it every night orally, and it's almost impossible for most women to be absolutely compliant with 14 days a month or a daily pill of micronized progesterone. And that's when often you'll have difficulties with missing it for 1 or 2 days. That's enough for many women to cause bleeding. So let's discuss how to adjust HRT, stop breakthrough bleeding. Next slide, please, Simon. So again, I've just kind of summarized it in a couple of tables here, but we can talk more during question answer session. If someone is on sequential HRT, cyclical HRT, and are having prolonged or heavy withdrawal bleeds, the simplest way to try and address that would be increasing the dose or changing the type of progestogen or reducing the estrogen dose. So you could give more number of days of progestogen, say from 12 to 14 or 16 or 14 to 21. You could increase the dose. The commonest one is the natural progesterone, so from 100 to 200 or 200 to 300. Change the type of progestogen, maybe a better, more bleed control type of progestogen, such as Provera, norethisterone, or the Mirena coil is always good. Or you could reduce the estrogen dose. Many women find that they've gone up to an estrogen dose which is controlling symptom, and it's been there for many years. After a year or two, actually, their requirement may have come down. So you could step down from 100 to a 75 patch or a 4 pumps of gel to 3 pumps, and that itself will stop the breakthrough bleeding. Bleeding is, if it's happening in early progestogenic phase, again, increase the dose, change the type of progestogen. If you increase the number of days within that progestogenic regime or go up to double the dose of progestogen, often the bleeding will stop. If it's just spotting before withdrawal bleed, often it's indicative that there's not enough estrogen to maintain the background endometrium, and it kind of breaks in clusters, causing the breakthrough bleeding. So if it's a typical history of mild spotting before they come on a bleed, you might want to slightly double the estrogen dose or increase it a little bit by 25%. That might stop the spotting. These are not many. And then irregular bleeding, if there's no pattern at all, it's happening all the time, certainly time to change your preparation. So you could again change the number of days or increase the progestogen dose. So the consistent message here is increase the dose or increase the number of days of progestogen. That's the most likely strategy which will help in the beginning. For continuous combined HRT, again, either lowering the estrogen dose or increasing the dose or changing the type of progestogen will help. For some women, despite all the permutation combinations, you might still have to switch back to sequential HRT for a while and then come back to continuous combined after a 6-month or a 1-year sequential HRT. There are, of course, all the other options which we do go to. For example, Mirena coil is very useful, especially in the perimenopause. Stopping, restarting with a different HRT can help. Fixed dose combinations orally can help a lot. So because we give separate transdermal estrogen and a separate natural micronized progesterone, that's when most of the problems with compliance happen. Most of the mismatch between estrogen and progestogen happens. If you can allow the woman to be on an oral fixed dose combination, there's no obvious thrombosis risk. Healthy women below the age of 60, try and encourage that. We've gone far too down the road of transdermal for everybody, but oral fixed dose combinations will work very well for bleed control for many women. And hopefully we'll look at an example shortly. Tibolone can be useful for those with chronic pelvic pain, endometriosis, very sensitive to hormones. Often tibolone works well as a bleed-free HRT, second line. And then finally, surgery. You can resort to endometrial ablation or resection or hysterectomy in refractory situations, and then keep patients on HRT. These will be very few and individualized decisions depending on patients' response. Next slide, please. A monthly progestogen, so this comes straight from the guidelines, how much of progestogen to give in terms of sequential or continuous HRT. If you're giving monthly progestogen dose in proportion to the estrogen dose, that is what is recommended. And if you're giving cyclical, that's at least 12 days every month. So the minimum duration would be 12 days of micronized progesterone every month. It's a little less, about 10 days with a stronger progestogen, such as norethisterone or medroxyprogesterone acetate. But that's the minimum required for endometrial protection if you have to draw a line between 10, 12, and 14. Women who are taking a sequential preparation above 45, by the time they get to 5 years use of sequential HRT or 54, whichever comes earlier, it's best to change to continuous combined, because we know that beyond 5 years of use, there will be increased risk of endometrial hyperplasia with a sequential preparation for these women, and you can usually change to continuous combined by 5 years. Next slide, please. Then you have Mirena coil. This is very good in perimenopause with background menstrual activity, which keeps causing problems with breakthrough bleeding. The Mirena might be the best solution, but of course, not everyone wants to have a Mirena. Oral preparations, as I said before, can provide higher rates of amenorrhea compared to a separate transdermal estrogen with a micronized progesterone. So if there are no risk for thrombosis, consider some of the newer oral preparations that combine the natural progesterone or a dydrogesterone. These are equally breast-friendly and very low risk of thrombosis. Whether it's the Famostone range or whether it's the Bijuve, you've got plenty of options which can give you better bleed control rather than separate estrogen progestogen. And finally, of course, if there is vaginal GSM symptoms, then vaginal estrogens will be the best treatment. Next slide. Just to give you an example of patient case study. So this is a typical 52-year-old postmenopausal woman. BMI was 26, had gone through menopause a couple of years ago, had significant vasomotor mood symptoms for about 18 months, tried non-hormonal therapies, did not want to go straight to HRT, decided to have alternatives, but of course symptoms continued. There's no other previous significant medical or gynae problems other than mild endometriosis in the past. We started her on estrogen gel, 2 pumps daily, and a natural micronized progesterone, 100 milligram orally daily. This was a GP referral, of course. And so the GP had started the patient on the estrogen gel and the micronized progesterone. Breakthrough bleeding happened after about 3 to 4 weeks of being on this HRT on and off. The GP advised to monitor until 6 months. That's good because the pathway was followed. Compliance was okay. She was definitely taking them as much as possible accurately. The bleeding had not settled, so she was referred for an urgent scan at the time. The examination findings in the clinic were normal. The scan also showed a normal ET of 3.3. The progesterone was increased to 200 milligrams. That would have been the next best step to do, but she was still bleeding after 3 months of a change. It was less heavy, but more frequent intermittent spotting, and she still was very compliant. So there was another scan then 6 weeks later, which still confirmed a normal thin endometrium, which is what we see in majority of our patients. No other abnormal findings. She was then switched to an oral fixed dose combination. So by the time she reached us with a complex situation like this, we decided to switch back to oral estrogen combined with dydrogesterone, a daily tablet, and that sorted the bleeding after a couple of months. She's happy to stay on this. She understands the pros and cons of oral estrogen, but she's healthy. She's under the age of 60. So we decided this would be the best approach to continue rather than come off HRT completely. So just a typical example where we might have to try 2 or 3 different approaches until we get the right approach for the patient. I think with that, I'll finish my slides, but hopefully we'll get lots of questions in the end. That's just a summary of the same thing, so I won't take more time here.
Great, thank you very much. I will just very briefly talk to you about the changes to the urgent suspected cancer referral form, which have come about partly because of the introduction of the National Unscheduled Bleeding Guideline, but also because of the audits we've done across London, not just in NCL, which have shown that RACE 125 of 35 has created a lot of unnecessary referrals in premenopausal women. Also asymptomatic postmenopausal postmenopausal women with a thickened endometrium on scan. So for endometrial cancer, we now have the 2 previous guidelines of postmenopausal bleeding or an abnormal scan. Asymptomatic women have been included now with an endometrial thickness of more than or equal to 10 millimetres being the arbitrary cutoff that we've come up with. That's what the UKC Tox study felt was an appropriate compromise so that we don't miss too many endometrial cancers, but we're not over-investigating well women. There's also the criteria as part of the unscheduled bleeding guideline. If you have a thickened endometrium on urgent ultrasound, if you're a high-risk patient, or if you can't access a 6-week scan by the direct access route. So we'll be monitoring those referral forms and how that affects demand and capacity. Just moving on to the next slide, please, Simon. These are the new proposed guidelines for referral for a suspected ovarian cancer. They are still being ratified, but hopefully will go through. Abnormal ultrasound, CT or MRI, or an abnormal physical examination where it's not obviously a uterine fibroid causing a mass. And then the new change that we're making based on a super paper by Funston et al. In 2020, I think it was, they looked at 50,000 women in primary care who'd had a CA-125 taken, and they looked at the rate of ovarian cancer. They also identified the rate of other cancers, and they determined an age cutoff for CA-125 for each age group, which gave a 3% risk of ovarian cancer or more. And that's the cutoff where NICE mandates an urgent suspected cancer referral. And it shows that in women aged 40 or under, you need a CA-125 of more than 100 to give you that kind of risk of ovarian cancer, a CA-125 of more than 50 in women between 41 and 49, and in women over 50, the old cutoff of 35 or more gives an appropriate risk of cancer. The risk of cancer in postmenopausal women over 50 with a CA-125 more than 35 was actually 10%. 10% were diagnosed with ovarian cancer in that study, and 12% were found to have another cancer. So we've also added a little guideline underneath to say, be mindful of patients who have a raised CA-125 but a normal gynecological ultrasound. Those patients need to be assessed for symptoms that may represent another cancer. Lung cancer, breast cancer, hematological and pancreas were very common in these groups. And it's worth safety netting those women to come back to you. Consider doing another CA-125 over a period of weeks just to see what the trajectory is. So this again is a new criterion which we're going to keep an eye on and look at how it impacts demand and capacity. And we're also working with Claire and the other leaders of the non-specific cancer pathway to look at whether we can automatically move patients from this pathway to that pathway if they have no gynae malignancy. So the other categories still remain the same, but the main changes are for endometrial and ovarian cancer. I don't think I've got another slide there. Simon, would you just go ahead? There we go. So the only thing that my colleagues in secondary care have asked me to stress is please ask patients to comply with the urgent suspected cancer pathway. Let them know why you've put them on it and that it's really important that they prioritise investigations and come to the first appointment that's offered to them. We really struggle to get people through the 28-day faster diagnostic standard because patients don't come to their first appointment. The sooner they attend for investigations, the sooner we can either reassure them that they don't have cancer or we can crack on and get treating them. So that's just a plea from everyone working in secondary care. So I hope those have been helpful explanations of the guidance. We will be auditing the clinics to look at how that impacts our 28-day compliance, how many referrals we're getting and for which of the criteria. We're going to keep an eye on the 6-week ultrasound capacity so that you in the community have the reassurance that you will always be able to get a scan if you need it. If we're worried about the 6-week capacity, we will work on an alternative pathway that's not on the 2-week wait pathway, but is potentially outside of that. So we will keep an eye on that. And we'll also monitor our endometrial cancers to make sure that there isn't any delay in diagnosis because of the changes brought about by this pathway. So thank you very much for your attention. Please do ask any questions. I'm hoping Vikram can answer them all.
Thanks very much, both of you. That's absolutely excellent. Really great talk. And thanks for, we've obviously said we're going to circulate the slides. There's been a bit of some questions in the chat about that, but we'll circulate those to registered people. And of course, you can find it on our YouTube channel. Anybody can find this on our YouTube channel. So I've got a question here from Sarah Scott, who just posted as I was speaking. Sarah, do you want to speak your question, or do you want me to read it out?
Yeah, I can speak it if you can hear me.
Thank you.
Yeah,
absolutely.
It's just it's great talk. Thank you very much. It's been really, really, really useful. And this is Vikram, I think, probably about the HRT. You mentioned making sure you change a woman from cyclical to continuous HRT by the 5-year point to protect their endometrium. We often have a lot of women who are maybe switching after minimum 12 months, but probably we're seeing women changing after maybe 2 to 3 years. Is there any, and they're doing fine on it, is there any disadvantage of that, of us switching them earlier?
No, not at all. I do the same. I offer to switch after the first year. Most of them will switch between 12 to 24 months, I guess. But there's no disadvantage at all. In fact, you could argue there's a bit of advantage rather than staying on cyclical, as long as the woman does not wish to be or insist to be on a cyclical. And you might find that for younger women, anytime between that 1 year to 5 year window, it's between you and the patient, you can switch to a continuous combined.
Great, thank you very much.
And Marita, do you want to speak your question? Hand up?
Yep. Can you hear me okay?
Yes, we can.
Yeah,
we can.
It's along the same lines, actually. It was mainly women with a premature menopause or primary ovarian failure who will be started on HRT. Does the same rule apply? Because many of those stay on sequential till later. And is the risk the same if they go on beyond 5 years?
So I don't think we have data for that. And correct me, Nicola. So most of the evidence about switching at the sort of point of 5 years comes from women above 45. So women who have had natural transition to menopause or above the age of 45. We don't have a similar equivalent data set for younger women who are on HRT in their 20s, 30s, 40s, or below 45. So again, here we kind of take a pragmatic approach and say if the woman wishes to be on cyclical HRT, because one would expect nature to be giving them bleeds if they hadn't been on POI. And if they have a very strong wish to stay on cyclical HRT, they want to do egg donation IVF, fertility treatment, then we can keep them on cyclical HRT. And at the age of about 45, that's when we start discussing you might be better off now transitioning definitely to a continuous combined. So as you rightly pointed out, it's a slightly different population, no same confirmatory data as in the older age group. And you can offer them to stay on cyclical till 45, but that's based on experience, not hardcore evidence.
Thank you.
Thank you. Any other questions? Anyone got their hand up that I can't see?
Yeah, I've got a question.
Off you go.
It's just regarding progesterone. Normally when we prescribe, I know the BNF says for sequential it's day 15 to 26 and for continuous it's day 1 to 25. Normally when we prescribe, we just tell them last 2 weeks of the cycle or for the full month. Is that any issue with that, or is that okay?
No, so you're giving the correct advice. The BNF with the continuous HRT is not appropriate advice because they allow you to take the capsule for 25 days and then there is a gap. That means you will still be inducing bleeds for majority of women, and that's not continuous, that's still sequential. So what you're telling is right. If it's continuous combined HRT, it's every day without a gap progesterone. And if it's sequential, you can choose whether it's the first 14 days or the 14 days from day 15 to 26. That depends on women's preference or convenience. But that's completely normal, correct advice.
So Vikram, thank you. Have you, is there something formal going to the BNF team to correct that?
I had heard rumors of that. I don't know. So I think there were representations to BNF to say maybe they need to put in a line or correct it, because I think the difficulty for BNF is that when the products were licensed, they were licensed with this regime.
Indeed.
And if they have to put off something like that, it would have to be made clear it's an off-license use. That brings in the difficulty, I think, for them. But it should be on the packaging by now because it's such a common problem we have.
Right. Nicola, do you have anything to add for that or not? No. Yeah, that's really difficult, of course. If it's on the packaging, it's one thing. If it's not on the packaging and no one is prepared to be absolute about it, it's really difficult for primary care as well. So, yeah. Any questions? I've got one, otherwise, while people are thinking of some others. So, one of the things that women often will say informally in a clinic situation, in a one-to-one experience, but are unlikely to write about in an electronic e-consult, is that in fact their compliance with the progesterone is really quite low and kind of vague, pretty intermittent. And people will say, as you described, oh, it's difficult to remember it at night and all sorts of things. They're also a bit some people talk about worry that they have a progesterone and breast cancer, and some of the stuff that they see comments about that, whether it's social media or, health pages in the newspapers or whatever. Do you have a view as to what might, where are we with that? Are there any trials ongoing at the moment that are looking at pretty, it seems to be certainly more common probably in women over 50 to 60, people who are kind of quite used to taking the HRT, and then their kind of compliance drops off as they feel they're in charge of it all. And people are, certainly certain women do present the anxiety about progesterone and breast cancer. So I guess the question is, are there any trials that are ongoing that might help us answer this question? And what might we do in the meantime, apart from obviously just saying, well, the current guidance is this and anything else is not safe?
So I think two things there. So there's a registry being set up by the BMS, British Menopause Society, with Endocrine Society. And I think that is precisely aiming to get these not reported or not recorded outcomes. So again, it will rely on patients filling forms and self-reporting their compliance. But I think the registry is meant to collect data for 5 to 10 years to begin with, to get a real-world experience of what happens with transdermal estrogen and micronized progesterone.
Yes.
So we will get a little bit better sense of what is happening on the ground, most women bleeding, missing their tablets, and what it actually means, how many of them eventually end up having investigations or endometrial pathology. There was one study which I think Professor Nick Penney was involved in. I have the reference. I don't know the exact the PubMed study title, but it did show. So they looked at compliance on continuous combined HRT and sequential HRT and endometrial pathology rates. And they found that people on oral continuous combined had a lower risk of bleeding and pathology than a separate estrogen and progesterone. And in the discussion, the author said one of the reasons this was thought to be the case is when they talked to women or tried to get the self-reported questionnaire, compliance was an issue in that group. So that was thought to be the cause why the endometrial pathology was more in that group. And it probably was a study of 400 to 500 women, so a decent sample. So studies are there which hint at this may be a phenomenon, and we'll see more of bleeding and pathology in the group. But we need far more data to actually make a case that we might be better off trying to get fixed dose combination than relying on women to take it separately.
Yeah. Okay. Thank you. We've got 1 minute to go. Are there any other extra urgent questions, or you could put them in the chat and we'll collect them and ask Nicola and Vikram to look at them later? Otherwise, I think it just remains for me to thank you very, very much, both of you, for a really, really great talk and really clear. Everything will be circulated, and obviously it'll all go up onto the websites, both for ourselves and also the ICB in terms of pathway websites. So that's great. And if I can just draw your attention, Catherine, someone's just mentioning a separate email address for contact, or Emma for their slides. Okay, it's been really great. Thank you very much. And we'll welcome all of you on our next webinar. Thank you very much.